to introduce Dr. Stephen Karpiak, who has a long distinguished history of advocating for older adults as a founder of the Arizona AIDS Project Wellness Center, as well as the executive director for Pride Senior Network, where he did research on the aging LGBT community. For the last 7 years, he has been the director of research at the AIDS Community Research Initiative of America, ACRIA. The ROA study, which you will hear about in a few minutes, is a large cohort study, has received significant recognition for giving the issue of HIV and aging priority status. It has been featured in multiple media, such as the New York Times, BBC, CBS, just to name a few. Recently, he guided the initiation of a ROA London research effort as well. So welcome, Dr. Karpiak.
Thank you. Good morning, all. It's interesting. I'm kind of sandwiched between two clinicians. So my remarks today are about the person living with HIV/AIDS. When I joined ACRIA almost 8 years ago now, I was charged with, and thank God for their trusting my judgment because ACRIA has funded all this work, is to describe who is this person living with HIV/AIDS. And I think that as we hear this emerging issues about clinical management, remember there's a person sitting here that the clinician and everyone else who provides care has to think about, and I think more and more and more, rather than just a pill. I mentioned my mothership is ACRIA, and I appreciate their support. We've heard a lot of statistics today, and I'm going to make them simple, but you don't have to have a PhD or do a statistical test to see. These are the number of people living with HIV/AIDS over the age of 50 from 2001 to 2007. It keeps increasing every year by about 2%. The study was just mentioned was ROA, Research on Older Adults with HIV. This is a study of 1,000 people living in New York City with HIV. It was preceded by, I've done my homework, by some pilot studies. And I must mention, when we did the pilot work and we published it, we went back into the community and told those people who are participated what we found. And that was very important in shaping ROA. Again, this is 1,000 voices speaking here. By the way, the book is out, I believe, this week. Mark is here, about ROA and it's all its details. I also want to say, as the last speaker said, I didn't do this alone. No one does research alone. There are many collaborators, many people who contributed to it, and especially Professor Cantor. Professor Cantor passed away last month. She was 88, and she was a luminary in aging research. I think she was the first researcher in aging who came together with folks in HIV and saw this problem coming and how we had to change. ROA is a very comprehensive study, and I can't even begin to hit just the highlights of it, but it was meant to be comprehensive. It was meant to look at many aspects of the person's life, and these are the major modules. They're all based, except for the demographics, on standardized tests, so we could take data that we got from those tests and compare it to other studies. What I'm going to do is just give you some highlights, but I want to emphasize ROA is largely about long-term survivors, people who've been living with this disease for 10 to 25 years. This is quite different. And if you look at the data, it follows very carefully the demographics of New York City, which is what it represents. This population is largely a Medicaid dependent, 83%, and this has policy implications. This particular data point is the most compelling to me from when I began this work almost a decade ago, that the vast majority, 70% of this population, live alone. This is completely opposite if you look at a control group, a comparison group in New York City. Living alone has enormous implications, not only for one's quality of life, but also how that person interacts with the medical care system. The transmission of HIV, if we look here to the left of the graph, if we look at people who were living with HIV for greater than 10 years versus those who are living for a shorter period of time, 1 to 5 years, all over age 50, you can see that the mode of transmission has shifted dramatically. And I think we've heard data earlier that also iterates this. Just to summarize, again, more than 80% rely on Medicaid. 54% are in recovery from some substance. Half of their friends do not know that they have HIV. 70% live alone. And only 15% of this population, this sample, which is pretty comprehensive, have a spouse or life partner. It has enormous implications about adherence issues. Stigma. Again, the person. When we ask them, who do you tell that you have HIV? Who do you disclose to? Of course, healthcare providers were the primary person that they would disclose to, of course, but not all. If they were going to an ophthalmologist or a chiropodist or whatever, they didn't necessarily disclose their status. And if you go down the line, you find that the people they least tell about HIV are people at their coworkers or people in places of worship. This has enormous implications because the African American community and the Latino community, who are heavily reliant upon faith-based communities for their existence and their culture, have largely not known about this. Here's a good, this is from the book. This shows how many people want to disclose. You have a secret. You want to tell someone. Look up the numbers. Latino, the highest, 43%. Black, 38%. White, 30%. Imagine having to keep a secret for every single day of your life. Comorbidities, we've heard a great deal about this. When we started ROA about now 7 years ago, this really wasn't an issue. We kind of thought it was, but we weren't sure. And this was a self-report from the clients, from the patients, the participants. And you can see here's the whole list. We've heard many of them today. And number one on the list, though, I want to mention is depression. It dominates as a comorbid condition. And as a matter of fact, my colleague, Dr. Brennan at ACRIA, looked at the number of comorbid conditions per person in the general elderly population and in ROA, and you can see the enormous number of these conditions. And this is a young population. The average age of ROA is 55. So a 55-year-old tends to look like a 75-year-old, and we've heard that today often. The overall correlation with depression, I'm going to talk about depression often here, there's a significant correlation of the number of comorbidities, the degree of their severity, and with depression. This data was just recently reported at the gerontological meetings, and this is a summary, and I want you to direct your attention to the right column. The right column says those people who have severe depressive symptoms that are untreated, what is the correlation or the number of percent of them who have also a comorbid condition? There's a very high correlation, which is really not unexpected, but it says something about this one comorbidity. Substance use was mentioned again by our prior speaker. It's an issue that's not taken into account as often